Hello friends, hi, I'm Dr. Shonali Chandra and I welcome you to our YouTube channel Medicine Decoded. Now we had the INICET exam recently got conducted last Sunday on 8th of May and we have come up with now the answer based solution to the expected questions. Now the questions so far in this exam were more or less not very clinical oriented, but yes, quite theoretical, and the options also were found to be very close. So there were a lot of confusing options as well. So yes, they had a lot of questions. They had picked it up from the Williams textbook. Now I understand that for many of you people in the undergrad level, you do not read Williams obstetrics. But having said that, the way that you could deal with those questions was using some little bit of elimination here and there, like I will tell you. So even with the knowledge that you already have, it's quite possible that you could have been able to attempt those questions. And there were certain questions which were from latest and recent updates, which probably most of you may not have been able to attempt, and that is okay because that would have been similar for everybody else. So let's get started with the questions one by one. So we have the first question here, which is of the following is not a criteria for a preterm labor. Is it cervical dilatation more than 1 centimeter, effacement more than 80%, more than 8 contractions in 60 minutes, or posterior position of the cervix? Now, I have always explained to you people that preterm labor is also diagnosed like any other labor, right? It's just that it happens preterm, less than 37 weeks. So regular uterine contractions with cervical changes observable over a period of time, right? So let's say that we all know that the position of the cervix has got nothing to do with the diagnosis of preterm labor, right? The position of the cervix is a component of the Bishop scoring, right? So let us just move on to what is the definition. Now, regular contractions accompanied by a change in cervical dilatation, effacement, or both. So to be able to see a change, we'll have to observe over a period of time, right? Either that or there are regular contractions and a cervical dilatation of at least 2 centimeter at the time of admission, right? So this is what the Williams latest editions also agrees to. So we all know, back to the question here, even if it's given cervical dilatation more than 1 centimeter, don't take that as an answer because the position of the cervix has got nothing to do with the diagnosis. Now, let's move on to the second question. Simple, straightforward, easy question. We'll not go into too much explaining of this. All of the following are routine antenatal investigations in pregnancy, except, so we all know, yes, we go for HIV testing, VDRL, screening for GDM. These are routine investigations. But yes, echo for heart disease, again, it's not a routine antenatal investigation. Now, next question. What is the true statement regarding genetic screening tests during pregnancy? Now, we're talking about genetic screening tests, right? So, we're talking about tests like quadruple test, triple test, and the combined screening for Down syndrome. So, those are the sort of screening tests we're talking about. Are they invasive? No. Invasive tests are the diagnostic tests which include amniocentesis and chorionic villus sampling, where genetic diagnosis can be made by sampling the cells, right? So they are not diagnostic, right? Gene mapping is not done as a part of screening, okay, is a part of screening. But yes, the screening tests, they help to estimate the risk of a genetic defect. So if the screening test comes positive, then further diagnostic tests are done because the screening test estimates the risk of genetic defect, right? So that is the correct answer here. Now the next question. Match the following histopath features with their corresponding germ cell tumors of the ovaries, right? So yes, multiple options may have been provided to you. We're going to match the columns here. So Schiller-Duval bodies, they are seen in yolk sac tumor, right? Schiller, and I have asked you to remember it with sinus tumor, right? Endodermal sinus tumor or yolk sac tumor is one and the same thing. And you all know that trophoblasts are seen, malignant trophoblast cells are seen in choriocarcinoma, right? Lymphocytic infiltration is characteristic of this germinoma. And cartilage, bone, and neuron, right? Germ cell, germ layer elements, they are seen in teratoma. So even if you knew, let's say, for example, 2 out of the 4 lot, you could have easily, come to the right answers in match the column type of questions as well. Now, next question. Now, see, this question is quite theoretical if you look at the options very closely together. But yes, you could still attempt it. Like, the options are so close that you would get probably confused. But let's just read through it. Now, which of the following statements is correct regarding labor pain? So, pain during early labor is mainly uterine in nature. Okay. Actually, you have to pick the incorrect statement. Which of the following statements is incorrect, right? So pain during early labor is mainly uterine in nature. Sensory innervation of the uterus is to T7 to T8 spinal cord segments. In the first stage of labor, pain is due to sensory fibers innervating T10 to T12 segments, and sensory innervation of the uterus, cervix, and upper vagina is from the Frankenhauser ganglion. So all of these points have been covered in the lecture also. All you needed to do was use a little bit of common sense in answering that question, right? So option number B and C both cannot be correct, that the sensory innervation is T7 to T8 and the pain is due to sensory fibers in T10 to T12 segments. So both statements cannot be correct at the same time. However, we know that option number A is basically true, right? And sensory innervation of the uterus, cervix, upper vagina, even if you forget what the Frankenhauser ganglion is or what it is we're talking about, I'm telling you that B and C are the possible answers here, because both of these statements cannot be true at the same time. So let me just put it as true here. And now, yes, in the first stage of labor, pain is due to sensory fibers innervating the T10 to T12 segments is the true statement. So the false statement or the incorrect statement here is option number B. So that would have been your correct answer, right? Now, let us just go through the diagram of the sensory innervation just to give you a little bit perspective of what they were talking about in this question, all right? So you have the sensory innervation, if you trace my pointer here, of the pelvic organ. So you have the superior hypogastric plexus, okay, that is the sympathetic plexus coming from the T10 through T12 and L2 segments, till L2 segments. And that plexus gives rise to hypogastric nerves, these are sympathetic nerves, right? So right and left hypogastric nerves. And then you have a pelvic splanchnic nerves also arising from the S2, S3, S4, which is the parasympathetic supply. And so the pelvic splanchnic nerves, they merge with the hypogastric nerves coming from either side here. So you get the, plexus here, which is the inferior hypogastric plexus, this one. Okay, inferior hypogastric plexus. Now, this inferior hypogastric plexus is going to supply the sensory innervation to the pelvic viscera, right? So the rectum, the uterus, tubes, bladder, and as well, and everything. So you have a vesical plexus, you have a rectal plexus. Forget about it. Focus on the uterovaginal plexus, right? So uterovaginal plexus here is going to give supply to the uterus, right? The medial part of the fallopian tubes as well, to the cervix, as well as to the upper part of the vagina. Now we know that the lower part of vagina and the perineum is being supplied by the pudendal, right? So you have this uterovaginal plexus, and the ganglion of this plexus is called as the Frankenhauser ganglion. So that's why this statement here, that the sensory innervation to the uterus, cervix, upper vagina is from the Frankenhauser ganglion, was a true statement. Okay, so just to recapitulate finally, pain of the uterine contractions travels through the inferior hypogastric plexus, right? T10 through T2 and L1 segments. Pain from the cervix, upper vagina travels from the pelvic splanchnic nerves. Pain from the low vagina perineum travels through the pudendal nerve, right? So that's why during early labor, the pain is referred to all over the abdomen, whereas pain due to a cervical dilatation, right? So in the later part of the labor, woman starts also complaining of pain at the back side. Okay. Now let's question what is true regarding anti-Mullerian hormone, right? So this testing for AMH is being done very frequently these days. We have a lot of infertile couples and we're doing these tests, which is testing for anti-Mullerian hormone. So they've picked up a question on that. Now, see, now this is very interesting because they kind of give an option which is something to do with clinical aspect, right? So it correlates with the outcome of IVF treatment, right? Interesting. Let's go and look at it. It is done on day 2 of the cycle. It's a lipoprotein, whatever secreted by granulosa cells. It's decreases the sensitivity of preantral follicles? I would say it's a tough question because we have very, very close call of options here. So it is not a lipoprotein. First of all, it's a glycoprotein. Okay. So, however, it is yes secreted by granulosa cells of preantral and antral follicles. The entire statement is not correct because it's a glycoprotein. It's done on day 2 of the cycle. First of all, it is not dependent on the day of the cycle. This testing for serum AMH can be done anytime during the cycle because it's the levels of serum AMH, they are not dependent upon gonadotropin. So this is entirely wrong. Now you people must have gotten confused between option number A and D. All right. So it correlates with the outcome of IVF treatment. What does that mean? That means, see, it does not correlate with the IVF treatment. I have told you earlier also that it is a testing for ovarian reserve. So what does it directly correlate with? It correlates with the ovarian reserve. Does that mean that a woman with poor reserve cannot conceive on IVF? No, it doesn't mean that. It just means that she has poor reserve, she needs treatment, right? And the dosages of gonadotropins which will be required to stimulate her now would be more. So it does not directly correlate with the success of IVF treatment or not, but it does correlate directly with ovarian reserve, right? So the leftover option is option number D, which is the true statement. It decreases the sensitivity of preantral follicles to respond to FSH. I'll tell you what that means. But let us just go look at what are the important basic points which you have to remember about AMH. The references from the Sperov's textbook of clinical gynae endocrinology. So this is the best reference textbook for gynae endocrinology and infertility to have. So AMH is produced by granulosa cells of preantral and small antral follicles, all right? And the number of antral follicles basically correlate with the size of the residual follicular pool. And that is why you see AMH correlates with ovarian reserve. The levels decline progressively, becoming undetectable after menopause, right? Now, because AMH derives from preantral and small antral follicles, levels are thought to be gonadotropin independent, okay, with little intervariation between the cycle days. Next, in the general IVF population, low AMH threshold values, they have a sensitivity, specificity, all those numbers that you see are way lower down in line, right? So they have poor predictive response to stimulation, right? But they have not been proven either sensitive or specific for predicting pregnancy. So not predictive for successful IVF, or not whether IVF will be successful or not, but they're definitely predicting poor response to stimulation. So maybe more dosages of gonadotropins will be required to stimulate the woman's ovaries when her ovarian reserve is low. Now, moving on. Next, see, it is a member of the TGF beta family, transforming growth factor. So it's a glycoprotein here, right? Now, it is produced by granulosa cells and it may play a role in oocyte maturation. How? Because it inhibits oocyte meiosis and follicular development. I'll just try to explain what they're trying to say here. So you remember that a number of follicles are recruited into the menstrual cycle each month, right? These are the smaller, let's say, antral follicles, okay? Let's say these recruited follicles, which were primordial follicles, they were recruited and then they grew on to become the antral follicles. And ultimately, only one is becoming the dominant follicle and the others are going to suffer atresia, right? So you remember that these growing antral follicles, they would secrete estradiol, right? Rising estradiol levels, but still not peaking. So rising values, but low levels, okay? Rising, but low levels, not yet peaking. Remember, I told you that these growing follicles also secrete inhibin B, right? And the role of this is to inhibit FSH, right? Decrease FSH, right? So the FSH support to the lesser antral follicles is taken away, and the dominant follicles continues to grow because it has the maximum number of FSH receptors. So this is how the dominant follicle selection takes place. Now, what is the role of AMH here, right? So the AMH decreases, you see, the sensitivity of antral follicles at the local level, right? It decreases these sensitivity of antral follicles, the lesser antral follicles at the local level to respond to FSH, right? So AMH at this point in time helps in this process of selection of the dominant follicle, right? So let us just see the option now. Last one, it decreases the sensitivity of antral and preantral follicles to respond to FSH is the correct statement. So this would be, I'd written antral follicles, but yeah, this would be preantral and antral follicles, which at the local level will find difficult to respond to FSH because of the AMH secreted. But even then, one of the dominant follicle will continue to grow because it acquired the maximum number of FSH receptors, right? So the question had, yes, you could probably attempt this question, but then yes, it would need a lot of time thinking about this question because yes, this tested your deeper theoretical knowledge about the menstrual cycle and its regulation from the concept of selection of the dominant follicle. Now, let's move on to the next question from preeclampsia, aneclampsia. We got 2 or 3 questions here. Interesting ones. Let us see this one. Which of the following is an incorrect statement regarding magnesium sulfate use in preeclampsia, right? Now, please remember that these are all recall questions, okay? So maybe I've got certain options incorrect, or maybe certain options are here and there. So if you have any suggestions regarding options that I have missed or miscalculated, you please put them down in the comment section. So it causes uterine relaxation in a dose-dependent manner. It has anticonvulsant and antihypertensive effect. Now, I don't even want to read the other options, my dear friends, because you have to identify the incorrect statement. And I've told you umpteen number of times that it is an anticonvulsant, right, and not an antihypertensive, okay? So magnesium sulfate, yes, has action on the central nervous system, by virtue of which it exhibits anticonvulsant properties, but it is not an antihypertensive, right? When you have to deal with hypertensive crisis, you don't give magnesium sulfate, you give the antihypertensive drugs, IV labetalol, like the drug of choice. So this is entirely an incorrect statement. So this is the one, this is the incorrect statement, and this is your correct answer. However, let us look at the other options also. It does cause uterine relaxation. Yes, magnesium sulfate has tocolytic properties, right? But for those tocolytic properties, there has to be, as and when the dose of the magnesium sulfate increases, that is when this effect on uterine relaxation is seen. In renal dysfunction, the initial loading dose can be given. Yes, so women with preeclampsia, eclampsia, as they come into the emergency or casualty, right, we have to give magnesium sulfate irrespective of the fact that we know that they could be having renal dysfunction, or they could be having decreased urine output, they could be having decreased glomerular filtration rate, okay? So despite that, because yes, I agree that, that the magnesium sulfate is excreted renally, right? But even then the loading dose need to be given, can be safely given. But for maintenance dosages, yes, for maintenance dosages, you have to titrate according to the GFR calculation. So this is also a true statement. This is also a true statement. Now, maintenance dose is given for 24 hours after delivery or last seizure, whichever is later. So this is also a true statement, right? So when you have started magnesium sulfate in a woman who's not yet delivered, so antepartum, let's say eclampsia she has had, right? She is not yet delivered, okay? So she had a convulsion, she went on to deliver. How long are you going to continue magnesium sulfate? 24 hours from her delivery, okay? Now, if let's say, for example, she had a convulsion in the postpartum period, okay? So let's say you had a patient with, severe preeclampsia, you had started her on magnesium sulfate, she never had any convulsion, but unfortunately, let's say she had a convulsion in the postpartum period, okay? Then you keep continuing magnesium sulfate for 24 hours from the last seizure. So whichever is later, delivery or last seizure, whichever is later, maintenance dose is given for 20 hours from that point onwards. Now, let us look at how they have picked up these very sentences from the textbook. So magnesium sulfate is not used or not given to treat hypertension, right? It exhibits specific anticonvulsant actions, right? So some proposed mechanisms reduce presynaptic release of neurotransmitter glutamate. So basically the excitatory neurotransmitters they are decreased in the brain, and potentiation of depressing neurotransmitters like adenosine action, potentiation of adenosine action. So, but however, having said that, magnesium sulfate does not cause, central nervous system depression per se on the whole. So it does not, affect the consciousness by itself. Now, blockage of calcium entry via voltage gated channels. This is also a proposed mechanism, and this also happens in the peripheral level. And that is why magnesium sulfate also has tocolytic properties, because it causes blockage of calcium entry via voltage gated channels in the smooth muscles of the myometrium as well. However, please remember that it is a dose dependent effect, right? So dosages like 8 to 10 milliequivalent per liter of magnesium sulfate need to be maintained in the serum concentration to exert the uterine relaxant effect. Now, moving on, let's have a look at this statement here from Williams' textbook again. So, see, magnesium sulfate is cleared by renal excretion exclusively. So, the dosages will become excessive if GFR is substantially decreased. So, toxicity of magnesium sulfate can happen if the GFR is decreased. Having said that, the initial 4-gram loading dose can be safely administered regardless of renal function. Okay, so one should remember that it is important to administer the standard loading dose and not to reduce it under the mistaken conception that diminished renal function requires it. Why? Because after distribution, loading dose achieves the desired therapeutic level. So the maintenance infusion rate should be altered, right? So how do you decide on that? If a woman is having decreased urine output, see, decreased urine output may not always necessarily correlate with creatinine clearance. So when you have decreased urine output, you should always, check on the plasma creatinine, right? And whenever the plasma creatinine levels are more than 1, serum magnesium sulfate level should be determined at periodic levels to check if the infusion needs to be continued, titrated, stopped, decreased, or whatever. Okay. Now, moving on to the next question, again, deep into the pathophysiology of preeclampsia. Now, I have been teaching and talking about these new markers for the last 2 years. They have been in the textbooks, and this is the time that they've been asked in INICET. Which of the following is incorrect regarding pathophysiology of preeclampsia? I am not entirely sure that this question was asked in this particular format. Okay, I'm not sure regarding that, but more or less, this is what they were asking in the options: SFLT, VEGF, decreased nitric oxide, and this ratio that they're talking about. Okay, so let us say that you do not even remember very closely about what happens to these two markers. Let's say you don't remember, forget about it. Decreased nitric oxide. Okay, so yes, what is nitric oxide action? Nitric oxide is vasodilator. Okay, now what is happening in preeclampsia? Vasoconstriction, generalized systemic vasoconstriction, right? So decreased nitric oxide makes sense. Yes, true, likely, right? Because nitric oxide by itself is a vasodilator, and in preeclampsia, what is happening? Instead, vasoconstriction is happening, so nitric oxide decreases. I think this is a true statement. Now let's have a look at closely this last option: thromboxane and PgI2 ratio decreases. Now let us just say that you do not really remember too much into detail about the pathophysiology, but let's hope that you remember a little bit of pathology per se. So thromboxane is coming from the platelet. Let me just take you to another image here. So these are the endothelial cells. Okay, these are the normal endothelial cells. Okay, and these endothelial cells release nitric oxide. Nitric oxide is a vasodilator. I'm saying the opposite is happening. Nitric oxide is decreasing from the endothelial cells. This is a direct result of decreased nitric oxide synthase enzyme in endothelial cells. What else is happening? See, vasoconstriction is happening. What else is happening? Endothelial damage is happening. Remember this diagram which I have taught you people? So endothelial damage is happening. Here, platelet aggregation is happening. Platelet aggregation is happening, right? So in preeclampsia, we have seen that obviously changes happens at the placental level, right? Then there is endothelial damage, and then because of that also there are other underlying changes which take place in the body, which are responsible for the manifestations, for the clinical manifestations of preeclampsia syndrome, right? So thromboxane A2 is released from platelets, okay, and thromboxane A2 helps in platelet aggregation and will help in the clotting process. So thromboxane A2 increases, okay. Prostacyclin, PGI2 is prostacyclin. Now prostacyclin is the potent vasodilator. What is happening? Vasoconstriction is happening. So prostacyclin is actually coming from the endothelial cells only, isn't it? Prostacyclin is coming from endothelial cells. It's a potent vasodilator, and here vasoconstriction is happening. So prostacyclin decreases, right? So what happens to the ratio of thromboxane to prostacyclin? The ratio increases. So let us just go back. Thromboxane and prostacyclin ratio does not decrease, instead it increases. So this is the incorrect statement, and that is your answer. Okay. Now coming back to SFLT and VGM. So before that, since this question has been asked, now I will again remind you about the pathophysiology. Okay, there are many theories. One is the theory of your defective placentation. Then there are other changes that take place like prostaglandin imbalance, right, and the angiogenic and anti-angiogenic factors involved in the pathophysiology. So there is incomplete trophoblastic invasion of the spiral arteriole. So this is normal, complete invasion of the spiral arterioles. So this is the decidua basalis. This is the myometrium. So involving superficial part of the myometrium also. What happens here in preeclampsia, on the other hand, that there is incomplete trophoblastic invasion. Only in the decidua part, the superficial myometrial part of the spiral arteries, they are not remodeled, right? So modeling is defective, spiral arterioles remain narrow. When they remain narrow, less blood is reaching the placenta from the maternal side, right? Less perfusion of chorionic villi, so placental ischemia. Ischemia leads to release of inflammatory mediators. All of this contributes to endothelial damage at the level of the placenta, as well as wherever these inflammatory mediators are going to seep into the general systemic circulation. All of the in all those places there is going to be endothelial damage. So endothelial damage is the centerpiece of our pathology here. Now, if you move on to see what are the new predictors, right? So there are certain factors at the level of the placenta here, right? Certain angiogenic factors which favor this invasion of trophoblastic cells, right? So angiogenic factors favor invasion. There are also anti-angiogenic factors which inhibit the invasion of spiral arterioles, right? So in conditions where you see what has been seen in preeclampsia is that the angiogenic factors decrease, right? So the growth factors, they are going to decrease, and the anti-angiogenic factors, right, they are going to increase. Now these anti-angiogenic factors are soluble as FMS like tyrosine kinase. So that is what is SFLT1, and soluble endoglin. These increase, right? Now if you were to ask why does this happen, this is something we don't know as of yet. This is still an enigma. Now, moving on to the next question. Now, which of the cervical cerclage procedures is not done during pregnancy? Now, I'm sure all of you have heard about Worms, Benson and Durfee, and laparoscopic, whatever being done in lap. The same Benson and Durfee can be done laparoscopy as well, can be done by open laparotomy as well. But what you must not have heard probably is about the lash procedure, because lash is something which was, I think, when you read the much older textbook, so when you Google it up, then only it comes, because it is not written in the newer textbook, because it's something of historical interest. Okay, historically, yes, this is the kind of cervical cerclage procedure which was done when the woman was not yet pregnant. Okay, so it was done, it is not done during pregnancy. So it is the only procedure lash here, which is not done during pregnancy, because this procedure involved, there's the cervix which is very small or defective, so it involved removing the portion of the defective cervix and sewing it back up, right? So that was what the procedure involved. It could not have been done in pregnancy with pregnancy in situ at all. So it is not done during pregnancy. Worms is a procedure which is done for emergency cerclage. Benson and Durfee is a kind of abdominal cerclage. You can do it laparoscopically as well. Any abdominal cerclage can be done by laparotomy as well. And we all know we have other vaginal cerclages procedures like McDonald's and Shirodkar's, which are more commonly done nowadays. So this is the answer to this is lash. Next question. High risk HPV does not cause, or maybe I think the question could have been the other way around. High risk HPV causes with multiple choice answers, so I'm not sure about that. But yes, high risk HPV causes cancer. It can cause cervical, oral, penile, anal cancer as well. It can even cause vulval cancer, right? But laryngeal papillomatosis is caused by the low risk type. So anogenital warts and laryngeal papillomatosis is caused by the low risk type. So laryngeal papillomatosis is seen when, there is the woman with active genital warts and she delivers a baby vaginally. So the virus can infect the throat of the newborn and cause laryngeal papillomatosis. Now next question, again from recent update. What is recommended dosage schedule for HPV vaccination in 9 to 14-year-old girls according to WHO's age guidelines? So up till now, we've been teaching that till 14 years of age, 2 doses, beyond 14 years of age, 3 doses schedule, right? Now, what did this, and I'm sure this is very recent. This is as recent as a news release which happened in April 2022. Okay, it is not even given in textbooks as of yet. So this is what it is about INICET, CET and examination from AIMS, that they could, yes, pick up questions from what is happening, recent things that probably have not come in the textbook. But if you've not been able to answer these questions and you've been confused regarding that, you need not worry, because it would be the same for everybody, right? Majority of the people may not have known this. So what is SAGE? SAGE is a strategic advisory group of experts on immunization, which keeps advising WHO regarding giving updates about immunization procedures. It recommends, now that is up to the nations, up to the different countries to accept it, to formulate it, to use it in their own national guidelines, right? So whether we are going to use it in our own national guidelines, we are yet to know. But what does it recommend? It recommends 1 or 2 dose schedule for primary target for girls 9 to 14, 1 or 2 for young women age 15 to 20. Okay, so technically what they are saying is that in younger women, what we wanted to do earlier was give 2 doses. Now, vaccine coverage in our country is anyways very less. So might as well give them the benefit of 1 dose and leave it at that. Okay, so 1 dose is giving the same efficacy as a 2-dose regimen. But they're saying that 2 doses with a 6-month interval for women older than 21. So they have, what they've done is reduce 1 dose. So earlier in this age group, there was 2 doses, less than 14 years of age. Earlier, more than 14 years of age, we would give 3 doses. They are saying decrease this to 1 dose and decrease this to 2 dosages. That is technically what they're saying. Avoid, okay, decrease 1 more dose. So according to WHO SAGE guidelines, it is 1 or 2 dosages. Okay, you can read this again: 1 or 2 dose schedule for the primary target of girls age 9 to 14, 1 or 2 dose for young women ages 15 to 20, and who are older than 21, 2 dosages. Okay. Now, next question. Arrange the following from adluminal to luminal. It's an easy question. Actually, if you had seen the diagram once in your life, you all read about spermatogenesis and the steps and everything, you all mug them up, right? And you have to know that if you've seen the diagram, you would know what is the arrangement from away from the lumen, adluminal, away from the lumen towards the luminal site. So you have this diagram here showing a seminiferous tubule where the spermatogenesis takes place, and this is a single cross section of the seminiferous tubule, and you can see a basement membrane here. You can see a basement membrane here. All right. The stroma is all around the basement membrane. Okay. And the Leydig cells are also in this location only. Okay. Now this basement membrane and these Sertoli cells, the yellow colored Sertoli cells, these Sertoli cells, they form tight junctions among themselves, among the various Sertoli cell tight junctions. So that creates a blood testis barrier here. You can see the primordial germ cells. So the germ cells are separated and kept safe here, right? Because there is a blood testis barrier created by the gap junctions and tight junctions, sorry, not gap junctions, tight junctions of the Sertoli cells. And the Leydig cells and the blood vessels, they are outside this blood testis barrier. Okay. Now let us have a look at in detail what are the contents. Okay. So we have here the basement membrane and we have the myofibroblasts. Okay. Myofibroblasts. Then comes the spermatogonia. Now, as the primordial germ cell is going to give rise to spermatogonia, then you are going to get the primary spermatocyte first. Then you are going to get the secondary spermatocyte. After primary, you are going to get the secondary spermatocyte. Then you are going to get the spermatids. And lastly, you are going to get the mature sperm or spermatozoa. So, what would have been the sequence? Myofibroblast, spermatogonia, primary spermatocyte, spermatocyte, and spermatozoa. So basically, as spermatogenesis takes place, you see the steps happen from the away from the lumen towards the lumen, so that the maturing spermatozoa, this one, the spermatozoa, they will come out they will travel through the lumen. Okay. So this was an easy question. Only you had to keep in mind that you had seen this diagram. Now, what is the half-life of letrozole? The half-life of letrozole is about 48 hours. Option number A is the correct option, 48 hours. Very direct question. Let's move on to the next question. Kassovitz law applies to what? Okay, now Kassovitz law, again, you don't find this in gynae or obstetrics textbooks. You find more often in the microbiology textbooks. What is Kassovitz law, or where you read about congenital syphilis and pathology? I can understand that it becomes difficult to visualize this because we do not see congenital syphilis that often. We have treated syphilis, right? The incidence of congenital syphilis, even in our country, has very much declined. We don't see it that often, but it is seen in congenital syphilis. Okay, so what is this law says? This law says that when a woman gets syphilis, okay, whatever, primary, secondary, tertiary syphilis, so a woman has syphilis, okay, during any stage of syphilis, if she's going to conceive, she can transmit that infection to the fetus, and then it can lead to congenital syphilis, right? So what happens is that the first time around she may have an abortion, the second time around, she may have then when she conceives the second time around, she may have a second trimester abortion. Then when she conceives the third time around, she may have a stillbirth. And eventually later on, a time will come when she will have a healthy newborn. So the logic being that as and when, the duration increases, yes, she transmits the virus, but she also transmits antibodies. She transmits the agent, that is the treponeme, not the virus. She transmits the agent, okay, treponeme, but also transmits antibodies as well, protective antibodies as well. So that is what the Kassovitz law explains, that with each subsequent pregnancy in a woman having syphilis, with each subsequent pregnancy, the outcome improves. Okay, so that is what the Kassovitz law explains. Now, direct question, repeat question, modified biophysical profile includes NST and AFI. No explaining here required. Next question, tough question. Very tough question indeed. so tough that I have scoured a lot. Okay, I've tried to talk to people, I've tried to find out what was the fourth option, and I have no clarity as to what was the fourth option. So it was so confusing. So all of the following statements are true regarding Manning score, except now I am not even sure if these three were the options, but there was some tough question on Manning score. Well, it includes fetal breathing, movement, stone, FHR reactivity. That's basically NST only, and amniotic fluid volume. So this is the true state. Right? You have to find the false state, but all are true except. Four is consistent. 4 less than 4 is consistent with fetal pH less than 7.2, and a score less than 2 is 100% predictive of fetal acidemia. Okay, something like this was given as an option. And the last option which I have for you is 4 is a consistent predictor of fetal acidosis. Now, on the one hand, they are saying a score of less than 4 is consistent with fetal pH. A score of less than 2 is 100% predictor of fetal acidemia. A score is a consistent predictor of fetal. These two statements, I think these two were the confusing statements, probably. The point here is that if you look at this diagram here this is a table taken from Williams, okay, biophysical profile. A score of 10, a score of 8 by 10 with a normal AFP, 8 by 8 NST not done. It means normal and a non-asphyxiated fetus. Okay? A score of 4, 0 to 2, probable fetal asphyxia, almost certain fetal asphyxia. The problem is with the equivocal score of 6 or 8 by 10 with decreased AFP, chronic fetal asphyxia suspected, possible fetal asphyxia, right? So the score performs fine when the score is absolutely normal or absolutely abnormal. Here, lowest and the highest possible. In between the scores is very inconsistent, right? And the problem with Manning score is also that when you want to see fetal movements, gross body movements, or fetal breathing and fetal tone and everything, right? And NST reactivity, all of these parameters, they mature over gestation. So these are these parameters which we see on NST and on Manning's or the biophysical profile, they are much appreciated when the pregnancy is beyond 32 weeks, when the fetus is beyond 32 weeks. At lesser gestation, the reliability of these parameters decreases, right? The reactivity of NST is also not well established before 32 weeks. So the score is not going to perform too well across all gestational ages, and that is also a major limitation of the score. So if you look at what the Williams says here, see, this is a graph. Don't get scared of the graph. This graph is just to show you that as the score decreases, this is the antepartum umbilical venous pH. This is the fetal depiction of fetal acidosis. As the score decreases, the chances of getting an acidotic fetus are also improved, because you can see here acidosis. Okay, that is what this graph is kind of telling us. But what I want to appreciate here, I want you people to appreciate is these arrows. What are these arrows? I want you to appreciate this is the standard deviations. So there is a very wide fluctuation. Okay, there is a very wide fluctuation. So look at this, what they say, that a biophysical score of 0 was almost invariably associated with significant fetal acidemia, whereas a normal score of 8 or 10 was associated with normal pH. An equivocal test is a poor predictor of abnormal outcome. Overall, these scores provide poor sensitivity to predict cord blood pH. This is what Williams had to say about the clinical utility of the biophysical profile. Again, they had gone deeper into the question, deeper into the topic, and asked you this question. So out of all of these statements, this is the false statement. Score is a consistent predictor of fetal acidosis. I would choose this as the false statement. Now, moving on to the next question. A 37-year-old unmarried woman comes for routine gynae checkup. She's sexually active, taking OCPs for contraception. She has a mother who has breast cancer. She has a sister who had ovarian cancer. So what advice do you give her? So stopping OCPs, I won't say. Okay, don't think about the history of breast cancer in the family as of now. There's a history of ovarian cancer also, and she can She can take ossipils as of now. We can reconsider that decision. Mammography, genetic testing, or prophylactic surgery. The important thing to note here is that she could be having the BRCA mutation, right? She could be a BRCA carrier. Hereditary breast and ovarian cancer syndrome. So it is important to first do this genetic testing and then decide on what is required. Okay, so genetic testing first and then decide what is required. At her age of 37-year-old, mammography is not that good. Okay, so anyways, first genetic testing, because she is a potential candidate of a BRCA carrier. If she is found to be of a carrier, then prophylactic risk reducing surgery will be an option for her. Okay, and to be able to counsel that, first we have to go for a genetic testing. Next question. A woman received tamoxifen for breast cancer therapy. How long after her treatment should she be allowed to conceive? Or a woman received tamoxifen for breast cancer therapy after surgery. Pregnancy should be delayed for how long? So technically, yes, you see, the correct answer to choose here is 3 months. Okay, 3 months is the correct answer to choose. Ideally, after a cancer surgery, especially a breast cancer surgery, conception should at least be delayed for 2 to 3 years. It seems reasonable. That is true for any gynae cancer. 2 to 3 years. It seems reasonable to delay conception because of the risk of recurrence. Okay, so recurrence are more common soon after treatment, and majority happen between 2 to 3 years after the treatment. However, there is a specific advice regarding tamoxifen. Okay, so if she has been on tamoxifen, that is what they say, that women treated on tamoxifen are at risk for several months after discontinuation, because the drug has a very long half-life, and therefore it remains in the system and it can be transmitted, it can reach the fetus also, and it is teratogenic. So it is recommended that for at least 2 months after tamoxifen completion, at least 2 months one should wait to try to get pregnant, and this is from the Williams textbook. And now that we're reading this reference from the Williams textbook, let us also read that what kind of contraception method should be used. So women who have been treated for breast cancer, they should not be given any hormonal contraceptives. Okay, copper containing intrauterine device is an excellent long acting reversible method for many. Okay, so copper containing intrauterine devices should be the best choice, and any hormonal method, estrogen or progesterone, doesn't matter, any hormonal method should not be used. Next question, straightforward, simple. There are less of simple questions in this paper. Now, which of the following factors decrease during pregnancy? We all know pregnancy is a hypercoagulable state. All clotting factors increase except factor 11 and 13. So factor 11 does not increase, in fact it decreases. Next question, which of the following statements is incorrect regarding acute pyelonephritis during pregnancy? Close call, very close options. Okay, all seem to be correct. Hospitalized, yes. Send blood and urine cultures, yes. It's acute pyelonephritis. Okay, pyelonephritis in pregnancy is an acute condition in the sense that it can quickly progress to sepsis if not treated. Okay, it can lead to complications like renal abscess. It can lead to complications like preterm labor also. So it is a dangerous situation which needs to be aggressively managed. So the patient needs to be hospitalized, and rapid institution of IV antibiotics is the mainstay. Should not delay it while we are waiting for culture sensitivity reports. So admit the patient, quickly send the blood cultures, quickly send the urine cultures. Start with rapid institution of IV antibiotics. Start IV fluids for hydration. You see, you have to flush the system. So hydration is very important, and you have to maintain a urine output of at least more than 50 ml per hour, because you have to flush the system, right? So the infection has gained access from the lower genital tract. From there, the infection has reached upwards to the kidneys. So you need to flush the system. So maintain urine output of at least more than 50 ml per hour. All of these are correct. IV antibiotics can be switched over to oral once the patient has been afebrile. All of this makes sense. Last option, discharge if afebrile for 72 hours, continue oral antibiotics for 5 days. Well, I am not very sure if these were the exact options, but if these were the options, then this is the false statement. So because it does seem like a reasonable thing, but only because the total duration of antibiotic therapy is more. Okay, the total duration of antibiotic therapy is not 5 days, it is more. So let's see here again, management of pregnant women with acute pyelonephritis chart, or the reference I've taken from Williams again. So the above points I've already told you. And let us just see here what is the change to oral antibiotics when afebrile. All this I have told you. Discharge when afebrile for 24 hours and consider antimicrobial therapy for 7 to 10 days. So 5 days plus 3 days, so 5 and 9. So basically, yeah, 7 or 8 days. So that is incomplete therapy. Probably that's why that was the most likely false option. So full 10-day therapy is generally preferred to be given. Now, next question. A couple is being investigated for infertility and the male partner has azoospermia. On further workup, he is found to have absence of vas deferens and seminal vesicles. What is the most likely cause? Again, this has been covered in the lectures, right? So let's see here, Coleman syndrome. Coleman syndrome can affect the males also. Okay, congenital GnRH deficiency. So congenital GnRH deficiency plus anosmia. Because of GnRH deficiency, delayed pubertal development, okay, and delayed pubertal development, if it happens in females, it is going to lead to primary amenorrhea. If it happens in male, it will again come with delayed male pubertal development and associated infertility, right? Klinefelter syndrome, again 47XXY. Okay, now in Klinefelter syndrome, we have shrunken testes, okay, shrunken and testes. And we have primary gonadal failure. Okay, primary gonadal failure. There is not absence of vas deferens or seminal vesicles there. Okay, Y chromosome microdeletions, again no absence of vas deferens and seminal vesicles. Cystic fibrosis is the correct answer here. Cystic fibrosis is a condition which is associated with, again, cystic fibrosis of the lungs, as well as congenital cystic fibrosis associated with congenital bilateral absence of vas deferens, which is also associated with absence of seminal vesicles. Not all patients with cystic fibrosis will have congenital bilateral CBAVD, okay? Neither will all patients of CBAVD, congenital bilateral absence of vas deferens, will turn out to have cystic fibrosis. But the two are often associated, right? So when we identify cystic fibrosis, we should check with this. When we identify CBAVD in a male on infertility workup, we should test for cystic fibrosis, but they are not always happening together, okay? Now moving on, another question on male infertility. So I have been seeing INICET and this NEET now moving towards, asking questions on male infertility. They've asked enough about female infertility. So couple is being evaluated for infertility. The male partner is found to have hypogonadotropic hypogonadism. The name itself is giving you so many clues. Hypogonadotropic. Gonadotropins are decreased. Hypogonadism. The gonadal steroids, that is means in this case, because we're talking about a male, is decreased. Okay. And when I teach you about the male hormones here, I'd give you the same concept as that we study in the females, right? Hypergonadotropic hypogonadism or hypogonadotropic hypogonadism or eugonadotropic eugonadism, right? When you talk about these hormonal imbalances. So let us see here, hypogonadotropic, gonadotropins are decreased, hypogonadism, testosterone is decreased, right? Which of the following is associated with this condition? So obviously, low LH and low FSH, because it's a multiple answer type. Low testosterone, this is also associated. And because of these reasons, the spermatogenesis is impaired. So it is associated with oligospermia or azoospermia, depending upon how much of the gonadotropin suppression is there. So these are associated. Low testosterone and high FSH. This is hypergonadotropic hypogonadism. Okay, this is hypogonadotropic hypogonadism, and this is seen with primary gonadal failure. This is seen with primary gonadal failure. Now, what about low prolactin? Now, remember in females also we've read about it, that hyperprolactinemia, excess prolactin causes a inhibition of GnRH, right? So, it is high prolactin which causes decreased GnRH, which can then cause hypogonadotropic hypogonadism, which can then cause hypogonadotropic hypogonadism. So it is not low prolactin. Had it been high prolactin, you would have ticked that also. Now, moving on to the next question. Now, which of the following is incorrect regarding management of diabetic woman during labor? Now, in my MCQ discussions, I have also taken this up, and I also tell you a little bit about how to manage diabetes during labor also. But again, when you read the options, you will say, okay, these are very long. A number of questions had very long options which you had to read. And this, I'm sure reading such long options is in itself getting confusing at times when you are in the stress of the examination hall. But if you just look at them now, let's see. In a patient planned for elective delivery, her nighttime dose of insulin and the morning dose is given as usual. Now, see, this is, I'll say why this is a clinical question. See, many times in exams, sometimes you may not know the other options, and it's fine because sometimes you just know the correct answer. So, come to think of it, especially for those people who have worked in the department, okay, who've taken the morning rounds, who have been there, at least one case of maybe a woman scheduled, a diabetic mother scheduled for an elective cesarean section, a diabetic mother scheduled for induction of labor, and you posted in the labor room, and you receive a woman from the ward saying that she's scheduled for induction of labor. The next question that arises is that, will she need the morning dose? Because she's been taking a morning and a nightly dose, right? If you're taking the night, as an intern, you're taking the nighttime ward rounds, okay? And you are given the job of managing, okay, the nighttime orders. And maybe you read in the notes somewhere that this woman is scheduled for induction of labor or an elective cesarean section tomorrow. So should she be getting the nighttime insulin dose? Well, in a patient planned for elective delivery, a nighttime dose of insulin is given as usual, but the morning dose is not to be given, because what will happen in the morning, the induction will start, okay, she will not be on her full diet. Very soon she'll go into active labor, she will be on IV fluids only. If she has a surgery, again, she will be off diet. So you cannot give her morning dose of insulin. This is true for any surgery that a diabetic patient undergoes, okay, that the morning dose of insulin is withheld. So this is the incorrect statement, period. Okay, now let us look at the other options. Regular insulin is given by IV infusion pump. That's true. Ideally, should be given by IV infusion pump in ideal circumstances. Where infusion pumps are not available, they give sliding scale insulin. Capillary blood glucose levels are maintained at approximately 100 milligram per deciliter. That is also a true statement. And the last, elective LSCS does not decrease the incidence of brachial plexus injury in the newborn. So yes, we know that, with diabetic mothers, with macrosomia, with the multiparity, with obesity, and with big size babies, there is a risk of shoulder dystocia. Does that mean that in all of these circumstances, should we be doing an elective cesarean section? Okay, now studies have shown that even doing an elective cesarean section does not necessarily decrease the incidence of brachial plexus injury in the newborn, because I have seen and I have done cesareans with big babies where you have to even deliver the shoulders out of a small uterine incision also. So even during that, brachial plexus injury may happen. Okay, So it does not decrease the absolute incidence of brachial plexus injury. So have a look at this. Have a look at this. Again, taken from Williams. The chart is there. The reference is there. You should at least see these charts. Okay, when you are reading when you're reading the explanations, right? So usual dose of intermediate acting insulin is given at bedtime. Do not give the long acting insulin at bedtime. Okay, morning dose of insulin is withheld. IV infusion of normal saline. If the sugar levels decrease below 70 milligram per deciliter, you have to give a dextrose infusion. Okay, so you have to achieve, you have to keep the blood sugar levels, capillary sugar levels. You keep monitoring them by glucometer every 2 hours, and you should keep them in the range of 100 milligram per deciliter. So you have the infusion pump. So when the levels go below 70, you start a dextrose solution. Glucose levels are checked every hourly or 2 hourly for adjustment in the insulin infusion and the glucose infusion, right? And you have to give the insulin infusion at a rate of 1.25 units per hour if glucose levels exceed 100 milligram per deciliter. Now, I also understand that for the undergrad level, this was a particularly difficult question to mug up all of these values, because you are not following them routinely as a part of your teaching protocol, all right? So maybe you are not aware of these values, and which I feel is fine. But to answer this question, at least you should have known that morning dose of insulin is not given as usual. So I believe this is an incorrect statement. This you should know. And last statement, again coming back to it, elective LSCS does not decrease the incidence of brachial plexus injury in the newborn. That is also a true statement. However, it is still recommended that with a diabetic mother and the estimated fetal weight, the diabetic mother and the estimated fetal weight on ultrasound being more than 4.5 kg, an elective cesarean section is offered to the woman. It is recommended. Will it decrease the absolute incidence of brachial plexus injury in the newborn? We are not certain about. Next question. So what we saw in INICET, I'll tell you what, is a lot of questions with, integrated approach, like leprosy. I mean, I don't see leprosy in my antenatal OPD. Leprosy is dealt with elsewhere. Okay, so this is medicine, microbiology, and PSM combined with obstetrics. So a pregnant woman with lepromatous leprosy and currently an MDT presents with type 2 leper reaction. What we should do? So first you should probably be aware of what is a type 2 leper reaction, and what do you do otherwise. Had she not been pregnant, what you would have done? Had she not been pregnant, you would have continued the MDT, right? You would have given her corticosteroids, and you would also have the option of giving her thalidomide, right? Okay. But here thalidomide is absolutely contraindicated. It is teratogenic. So you would continue MDT and start corticosteroids, even high dose corticosteroids, for the sake of the mother. They need to be given, they're safe, right? So you would continue MDT and start corticosteroids even if the woman were pregnant. Thalidomide is absolutely contraindicated. And when leper reaction happens while the patient is on MDT, there is no indication for stopping the MDT. So if you don't stop the MDT in a non-pregnant person, why would you stop it in a pregnant woman? Okay, antibiotics have no role here. So the correct answer is option number D. Continue MDT and start corticosteroids. Next question. Which of the following statements is incorrect regarding lupus nephritis during pregnancy? Now see, what I'm trying to tell you here, that we get hassled by so many options, but sometimes there is the clue in the questions. Okay, so let's say you are reading through, you're reading through pregnancy is ideally planned when disease has been quiescent for at least 6 months. So that means the disease has been quiet and she's not had any flare, and the stable condition is there at least for 6 months. It makes sense. Okay. Immunosuppression can be continued in lupus nephritis during pregnancy. In a lupus nephritis, no, not all women with systemic lupus erythematosus. Okay, so SLE is a connective tissue disorder with autoantibodies targeting the various systems. We're not going into that detail in this question and answer discussion. That is from your medicine textbooks. You can go back to refer to it. The obstetrics part of it is that obviously if there is going to be a lupus nephritis, okay, then there is an increased risk of complications in pregnancy, okay, increased risk of complications like preeclampsia, most particularly hypertension, right, that is going to affect the pregnancy badly. Secondly, SLE is also associated with abortions. When it is specifically associated with antiphospholipid antibodies, that is another pregnancy complication that can happen. Other than that, with SLE, there can be flares, SLE flares during pregnancy, which can get aggravated because pregnancy is an immunomodulated condition. So all diseases where, there is an immune mediated dysfunction, there is some sort of activity that will happen. Sometimes the disease may flare. Now, not all women with SLE will have a flare during pregnancy, right? Roughly in 1/3 cases, there is a flare. In 1/3 cases, the disease remains the same. And in 1/3 cases, the disease may even improve during the course of pregnancy. So it is very variable. So complications can happen. Like I told you, if there is already nephritis, then there is the risk of progression of nephritis during pregnancy. There is risk of preeclampsia, hypertension associated complications. So nephritis, lupus nephritis requires immunosuppression. Okay. So for the sake of, the mother and for the sake of the pregnancy, immunosuppression, if required, can be continued. Okay. Now, what would you give for immunosuppression? So there are various options which are being used in SLE for immunosuppression. So one of the options is high dose corticosteroids. Okay. So high dose corticosteroids are safe during episodes of lupus flare. For immunosuppression, high dose corticosteroids are safe during episodes of lupus flare. High dose corticosteroids are safe for lupus nephritis as well. Makes sense? So option A, B, C all makes sense. Okay, what will we do if there is an episode of lupus flare in pregnancy? We have to do something. So we can give high dose corticosteroids, that is safe. Now look at the last option. Aspirin, corticosteroids, mycophenolate, methotrexate, cyclophosphamide, azathioprine, all safe in pregnancy. Methotrexate is absolutely contraindicated in pregnancy because it will lead to death of the babies. It's a completely contraindicated in pregnancy. Under no circumstances methotrexate will be given. Okay. Cyclophosphamide is also contraindicated in pregnancy. Regarding azathioprine, is also a drug used for immunosuppression. If required, azathioprine can also be given. So when you talk about drug use in pregnancy, it has got to do more with risk versus benefit ratio. Okay. So considering the risk versus benefit ratio, azathioprine can also be given. But one drug among all of these, which is absolutely contraindicated, under no circumstances should be given to pregnant patients, is methotrexate. So maybe if you had no options, idea about option A, B, C, if you had known this, you would say that this is the incorrect option. So which of the following statements is incorrect? Option number D is the incorrect statement. Moving on. Which of the following statements is incorrect regarding PPH? More than 500 blood loss in singleton vaginal delivery is PPH. Prolonged labor, multiple pregnancy, chorioamnionitis, these are risk factors. True. Initial management is IV colloid. A hemorrhagic hypovolemic patient, you've read this in surgery, you've read this in obstetrics and gynecology, is IV crystalloid. And in a patient who is having that PPH at that moment in time, you have to aggressively resuscitate with IV crystalloids, and at least 4 times of the amount of blood loss that has been happening needs to be given immediately. So this is definitely the incorrect statement. Option C is the incorrect statement, and option number C is your answer. Okay. Now, option number D, volume of blood loss can be calculated by adding 500 ml for each 3 volume % drop in hematocrit. Now, I know for sure that option C is the incorrect statement. However, let us talk about option number D also, which is the true statement or the correct statement. Okay, so let's see option number D also. The volume of blood can be calculated by adding 500 ml for each volume percent drop in hematocrit. Now again, this has been taken from Williams, okay. So what happens is that there can be a situation where, you admitted a patient in the labor room, you checked the hemoglobin and hematocrit, then she went on to have a delivery. After the delivery, she's fine and she's stable, okay, or she may be having few symptoms, and you check her hemoglobin again, she looks very pale, that's why you check her hemoglobin again, hematocrit again, and there is a drop in hematocrit. Okay, so when will you say that significant PPH happened during the course of delivery? So if you have to make a retrospective diagnosis, okay, based on the change in hematocrit from pre-delivery to after delivery. Okay, so what is the logic behind it? The logic behind it is that let's say there is a blood volume of a woman, okay, blood volume of pregnant. How will you get the blood volume of pregnant woman? You will get the non-pregnant blood volume by a formula, okay, height, weight, and we'll get the blood volume, okay, in a non-pregnant woman. Now, volume of pregnant woman roughly on an average will be increased by 50%. Okay, so there will be roughly a 50% increase in blood volume. So you'll get a total blood volume. So this is the percentage average increase that had happened. Okay. So in a pregnant patient, when PPH happens and she loses whatever extra blood volume was added, okay, so there is an addition to the blood volume during pregnancy, okay, right? This is the additional amount of blood volume that is being added during pregnancy. If she loses this much, if this is lost during PPH, okay, it is said that there is no change in hematocrit. If this is lost in PPH, it is said that there is no change in hematocrit. I mean, if whatever blood volume she added, okay, let's say it was 500 ml or let's say it was 1000 ml, let's say it was 1000 ml. She added 1000 ml of blood volume during the 9 months of pregnancy and then happened to lose 1000 ml of blood during delivery. Okay, then she lost 500 ml of blood during PPH during delivery. If you check the hemoglobin and hematocrit, there will be no change in hematocrit. If she lose anything more than this, if she lost anything more than whatever amount had been added, there will be a fall in hematocrit. And for each ml, for each 500 such ml of blood loss, 3% volume percent decline of hematocrit is going to take place. So let us read this. Whenever the postpartum hematocrit is lower than 1 obtained on admission for delivery, blood loss can be estimated as the sum of calculated pregnancy added volume plus 500 ml for each 3 volume percent decline of hematocrit. So for example, if a woman added 1000 ml, okay, by calculating this, by calculating the, you calculate the non-pregnant blood volume first, then you calculate the average percentage increase. So let's, for example, say that 1000 ml was the amount of blood volume she added. Let's say her hematocrit fell by, let's say, 3%. Let's say her hematocrit fell by 3%. So 500 ml for each 3 volume percent decline. So you will add 500 ml to this and you will get 1500 ml as the amount of blood loss. If the hematocrit had fell by 6%, then you would add 1000 to the amount of blood loss. Okay, so 500 ml for each 3 volume percent decline of hematocrit, right? So this is the explanation, this is a detailed explanation of what the statement in the textbook means. So this helps you to roughly estimate the amount of blood loss in a retrospective manner depending upon the pre-delivery hematocrit and the post-delivery hematocrit. Okay, if you have these two values, you can roughly get an idea about the amount of blood lost during the course of delivery in ml. For that, you should know the height and weight of the woman, okay, so that you can calculate the non-pregnant blood volume, and then you can calculate the blood volume, percentage increase in blood volume also. Next question. A woman is brought to the psychiatric department for an episode of mania and needs to be started on therapy. Now, psychiatry plus obstetrics, so very integrated sort of questions they have asked, a couple of 3-4 integrated questions. She needs to be started on therapy. That is actually correct. An episode of mania and she needs to be started on therapy. What is the drug that is absolutely contraindicated because of use of teratogenicity? So all of these drugs are used for mania treatment. Now, most of the antipsychotic drugs used, they are typically safe in pregnancy. Okay, various antipsychotic drugs are safe in pregnancy. Carbamazepine, olanzapine. They're also, if the medical condition of the patient requires that she needs to be given carbamazepine, olanzapine, they're considered fine in pregnancy, safe in pregnancy. Now, among all of these, you have to have a doubt about sodium valproate and lithium. Okay, so lithium we know is also associated with Epstein anomaly in the fetus, but what is the chance? What is the chance that such an anomaly will take place? The chance is about 4 cases in 1,000 women. However, with sodium valproate, the chance of having birth defects is much higher. Okay, the chance of having neural tube defects is much higher. So, among all of these drugs, sodium valproate will be the drug that is most contraindicated. So, sodium valproate will be the answer here. And now let's look at the last question. Now, what is correct regarding ART therapy in a newborn of HIV positive women? Now, you could consider it a PSM question. You could consider a pediatric question. And I've chosen to discuss it here because I teach you this in the lectures also. So, what is correct regarding ART therapy in a newborn of HIV positive mother? So, according to the NACO guidelines, okay, all pregnant women, they are started on 3-drug antiretroviral therapy during pregnancy. Right, irrespective of the stage, whenever it is diagnosed, it is to be started. Okay, ART to all pregnant women. Okay, next that I keep telling you is according to the NACO guidelines. The other thing is that the vaginal delivery is the preferred mode of delivery. Cesarean section is for obstetric indications. The other component is breastfeeding. Okay, exclusive breastfeeding should be promoted. Exclusive breastfeeding should be promoted, and newborn should also get ART, that is syrup nevirapine. Okay, so these are the 4 components. Okay, now under no circumstances should mixed feeding be given. All right. Now the question they are asking is about exclusive replacement feeding. Now see, yes, in India, breastfeeding is very, very important for our newborns, and that's why it is recommended that exclusive breastfeeding should be promoted. However, if there is a family which can afford exclusive replacement feeds and want to go for exclusive replacement feed, then that is fine. Okay, that is also allowed. So the woman and the family can choose whether they want to go for exclusive breastfeeding or exclusive replacement feeding. What you need to tell her that yes, exclusive breastfeeding has its own advantages, and in any case, we are going to give newborn with the antiretroviral therapy after birth also. So, if exclusive breastfeeding, newborn needs ART if HIV positive. Newborn needs ART irrespective of whether the newborn is HIV positive or not. So, this is absolutely an incorrect statement. If exclusive replacement feeding, newborn does not need ART. No, even if exclusive replacement feeding, newborn needs ART. Right? So, what is the components? ART, vaginal delivery, exclusive breastfeeding, newborn syrup nevirapine. Newborn is given ART irrespective of the mode of feeding. So, exclusive replacement feeding, newborn does not need ART. That is also incorrect. If exclusive replacement feeding is being done, check newborn. If HIV is negative, ART is not required. That is also incorrect, right? Any infant diagnosis is done at 18 months. Okay, any definitive infant diagnosis is done at 18 months of age. So if exclusive replacement feeding is being given, newborn should be given ART till 6 weeks, right? So irrespective of the modality of feeding, okay, whether exclusive replacement feed, whether exclusive breastfeeding, infant receives ART for 6 weeks according to NACO guidelines, and that is the true statement. Option number D is the correct statement regarding ART therapy in a newborn of HIV positive woman. Okay. So with this, we finish off the discussion of the questions. So yes, there were well in all about 33 questions from Obs Gyne. Okay. And to top it all, about 6 to 7 questions were not even from core obstetrics or core gynae, but they had what integrated with a lot of medicine, and you saw in the last questions pertaining to psychiatry also with more to do with pharmacology. So yes, we did saw a significant number of integrated questions. We did not see many clinical questions this time in the examination. We saw theoretical questions. We did see a lot of questions being picked up straight from the standard textbook. But having said that, I gave you the examples of how you could at least try to attempt those questions. And I'm not even talking about just being in the retrospective manner of, of the people who have already appeared for the exam. This discussion is basically also for those people who are going to appear for the exam in the future. So if you have an idea about the sort of questions they are asking, please keep in mind that do not be hassled by questions with lengthy explanations or lengthy text, because many times even the lengthiest question will offer certain clues. So without losing your cool, if you read the question properly, it is quite possible that you can answer the questions with elimination. And even after studying all of this, you are still getting confused with two options. And that means that the options are too close, and it is better not to attempt such questions which are going to be difficult for the majority of you people, right? So we can think about these questions in a prospective manner, in the sense that we can strategize as to how we are going to study forward. So we are going to study forward by reading in detail, right? By jotting down the important points and by practicing questions where we are practicing the art of eliminating options more often. And most of these questions should be attempted if you are having a very conceptually grounded base. Conceptually also means clinical, conceptually also means the theoretical concepts are clear to you. Thank you.